Welcome back to Psychiatry Boot Camp. All right, after this episode, we will start going horse by horse through the psychiatric stables. By the way, how far do we think that I'm going to take this metaphor? Anyway, today we're talking more about the stables themselves and horses in general. Dr. Erick Messias is a psychiatric epidemiologist and the chairman of psychiatry at St. Louis University. Notably, he will also be my boss next year when I head back home to join the faculty at St. Louis University, where I'll be directing the psychiatry clerkship and seeing patients on the hospital consult service. Dr. Messias is going to tell us about how we derive population-level data on psychiatric health and how understanding where these numbers come from and how they're generated can help us in our clinical decision-making. He also shares some background on how psychiatry as a discipline got where it is today in terms of the DSM. You can especially look forward to his explaining that the secret to life is thinking about the world as a 2x2 table, and we will conclude with some wisdom about inserting meaning into daily psychiatric practice. And that last segment made for a really nice little meditation for me, so I hope you're like having your morning coffee or your evening tea when you end the episode so that you can kind of think about where you might insert his wisdom into your day-to-day. Without further ado, Dr. Erick Messias, welcome to Psychiatry Boot Camp, and I will ask you to introduce yourself to our audience.
Of course. Well, thank you for the opportunity. I enjoy talking about psychiatry and mental health, and when we can combine epidemiology and psychiatry is even better. The reason is my interest in psychiatry started in epidemiology, and my interest in epidemiology came from psychiatry. So I'll explain a little bit. So to introduce myself, I was born and raised in Brazil, in the northeast part of Brazil, which is more the rural and less industrial part of the country, and more tropical, more close to the equator line. So I grew up there. I did medical school, wanting to understand more about humans and human behavior. That's why I ended up in psychiatry. I always wanted to do research, and I did some research as a medical student. One of them was in epidemiology, which we can talk about. But then I came for residency training in the US because it was the best. Everybody agreed, both in Brazil and in Europe, actually, where I spent a couple months, that the US the best training available in the 1990s for psychiatry. And I came to the University of Maryland. I was very lucky to be given a chance to train at the University of Maryland, which at the time, and to this day, houses the Maryland Psychiatric Research Center, which is a research center dedicated to schizophrenia in particular. And I did my residency in the research track. And finishing residency, I moved to the other side of town, which is Hopkins, and I did a master's in public health and a PhD in psychiatric epidemiology at Johns Hopkins. Ever since, I've been in academic medicine. I practice psychiatry in academic settings in Brazil. Back in Brazil, I went back to Brazil for a couple of years. And then when I came back to Georgia, where my former mentor was, and from Georgia, we moved to Arkansas, where I stayed in Little Rock for 12 years. And I was associate program director in Georgia. I created a new program in Little Rock in Arkansas of residency. And I worked with Medicaid Arkansas, which I say that working with Medicaid Arkansas was my second MPH, and probably as informative as the one at Hopkins. I did that for a year, and I was doing outpatient, inpatient, always working with residents, always trying to think about psychiatry from a epidemiologic perspective, and always publishing and thinking, using databases, and teaching. So that's me. That's me in a nutshell.
Gotcha. So you're here to talk about psychiatric epidemiology. And of course, the theme of this season of Psychiatry Boot Camp is when you hear hoofbeats, think horses, not zebras. So we're trying to cover the most common psychiatric horses in terms of diagnosis. But I thought it might be helpful for our listeners to first back up and consider the more fundamental question: what is a horse and how do we know? So we frequently see numbers thrown around, like on board exams, study materials about prevalence estimates, etc. So why is it important for psychiatric learners to understand how these psychiatric statistics are developed?
So that you don't get fooled by biased studies. So it's important that you know what the reality really is. And when you say, think of horses, not of zebras, to me, you should know epidemiology, because you should know the distribution of disease in the population. More importantly, so I'll give you a further thought on the zebra, is that, but if you are in a zebra reserve, if you think about zebras. so it all depends on the base population, on the prevalence of your condition in the base population. So zebras are rare events, and horses are much more common events. So it's important that if you have to place a bet, if you're going to see a horse or a zebra, it's much more likely that you see horses. In psychiatric epidemiology, you need to think about substance use, how prevalent it is, right? So, for example, I'll give you an example. One of the questions people sometimes ask is, what's the most common psychiatric disorder? And the answer is, it depends. It depends if you include substance use or not. It depends if in the substance use you include nicotine or not. So everything depends on what's your base population. So as an epidemiologist, I'll tell you, in our language will be, it depends on what the numerator and what the denominator is. So sure. It's always about that. It's always about understanding what's the denominator here, what's my base population, and what's my numerator, what's my patient, what's my specific subpopulation.
So, when I see questions on my board exams, for example, I know there was one recently about what is the most common anxiety disorder, et cetera. Mm-hmm. How are those prevalence estimates developed?
Okay, great. So psychiatric epidemiology started, over when we had those big psychiatric hospitals called asylums. So we had numbers. We had numbers for how many people come in, how long they stay. We had numbers back then about the populations in psychiatric hospitals. But then, as time passes, a number of things happen. The most important event in psychiatry that we don't talk about, actually, that changed the course of psychiatry in the US was actually World War II. So World War II led to a huge problem, which was the number of men that were being excluded from service because of mental disorders. And it surprised the Army. The Army was not ready for how many men in the community were having anxiety, depression, schizophrenia, bipolar disorder, right? So that we call at the time manic depressive illness. So and substance use and alcohol and other drugs, cannabis at the time. So we started to study. So that's the first, what we call the first generation of epidemiologic studies. They go back to the asylums, to the big asylums, right? It's the numbers of chronic mentally ill patients in institutionalized. The second phase came from patients that needed treatment, patients in treatment, that we needed to understand how many are in treatment, how many people, how many men, how many women, how many kids, how many old folks with dementia. So we needed to know that. And then the next phase comes from what we call community-based studies. Community-based studies, the first big one was the ECA study, is the Epidemiologic Catchment Area Study. And that's dating myself, that ECA was the key study that actually I use for my dissertation. I use the third wave of the ECA. So the ECA came from the late 1970s, early 1980s. And this is, the final years of the Carter presidency. And the question at the time was, how many people actually have depression? How many people have anxiety? How many people have, problems with alcohol use? And we didn't know. We did not know. We could tell how many people were being treated, but we knew that there was a significant number of people untreated in the population. So this huge study was organized, and it was organized in the good old days, where 5 institutions, and I'll tell you the names and you know who they are, 5 institutions represented the country. So 5 institutions got together: Duke, Yale, Hopkins, WashU, and UCLA. Those 5 institutions created the 5 sites of the ECA, of the Epidemiologic Catch Study. The idea being that these 5 institutions could sample in the community to give us prevalences for the mental disorders in the population. Well, of the big names universities, which one is missing of the 5? Harvard, right? So Harvard was very upset. And the Harvard group decided to eventually start to criticize the ECA, saying, that's not really a national sample. That's actually a sample of 5 sites. And we can create a national sample. And actually, Ron Kessler at Harvard proposed the next big study, which is a National Comorbidity Survey. And the National Comorbidity, although I use the ECA, I believe the ECA numbers, I think they're very good. The National Comorbidity Studies, they use a probability sample of the whole population, about 10,000 people, and they are more recent. So I tend to use the National Comorbidity Survey numbers. They're available online. You can find them fairly easy. And those are the numbers that I use today. They are from the early 2000s. Since then, a number of things happen, of course, so there are new developments on technology, on surveys, survey techniques and tools that have changed how we look at answers. But the NCS, to me, are still the numbers that I go back to all the time.
So for the ECA and the National Comorbidity Study, did they bring in strangers on the street in person to these sites and do a full psychiatric interview, or were they calling people on the phone, or do you know the mechanisms?
Yes. So the different phases use different techniques. So because my mentor used to say, the prevalence of antisocial personality is about 1 to 2% in the population. So if you're hiring 200 interviewers, you're going to have a few that are going just to make up the answers at home. And you have to find a way to find who they are. So these folks knew the data, and they used it to develop better techniques. The latest approach that I remember from the latest waves of the ECA and the NCS, they use laptop computers where that would be recording the interview at random times without the interviewing knowing, so they couldn't make it up. So those are kind of quality controls, right? But before the quality controls, you need to understand that these are structured instruments. So in order to understand the importance of that, let me talk a little bit about psychiatric diagnosis, right? So psychiatric diagnosis, and I think I remember your first interview was with Alan Francis that organized DSM-4.
And he's actually going to precede you in this season as well. So they'll have just listened to Alan Francis before this.
He may tell a slightly different version of this story.
Perfect.
But I will. So if you look at history, the Diagnostic Statistic Manual started after World War II, because we wanted to find a way to better diagnose mental illness, right? So the first edition of the DSM, I called it the Adolf Meyer edition. The Adolf Meyer edition was an edition about environment and about reactions to the environment. That's Meyer's contribution to what he calls psychobiology. It was very unreliable. The second edition of the DSM is the Freudian edition. So it's when after the war and the influx of psychoanalysts from Europe, you have a heavy influence of psychoanalysis in American psychiatry, and it became even less reliable. So in the late 60s, early 70s, there was a big study done to actually compare how we are diagnosing mental illness in the US versus the UK. And you will never forget the name of this study, because the way I teach it is called the US-UK study, which basically you can read it as "you suck," because it showed that psychiatric diagnosis was very unreliable. So basically, they got some psychiatrists from the UK, brought them to New York, had them interview some patients, and they brought American psychiatrists to London and had them see patients there, and they compare the list of diagnoses. And basically, the American psychiatrists were much more likely to diagnose schizophrenia, because there was this whole psychoanalytic theory about schizophrenia mothers and all that type of stuff, schizophrenogenic mothers. And you had the UK folks diagnosed bipolar much more often, because they use lithium more often. Lithium actually came to the US very late for another reason. There's another lecture on the history of psychopharmacology that has to do with why lithium took so long to come to the US. So there was all these differences. The big change happens actually right here in St. Louis, and it was at WashU. It's called the St. Louis School of Psychiatry. The St. Louis School of Psychiatry. It's basically WashU. WashU at the time had a group of psychiatrists that called themselves the neo-Kraepelinians. And they actually sat down and wrote criteria for diagnosing disease and mental illness. And they were very opinionated, but they're very reliable. They were extremely reliable. So basically, they wrote down criteria. And that's the beginning of DSM-3. So DSM-3 is the WashU DSM, basically. It's based on the set of criteria called the Feiner criteria. Feiner was a resident at the time at WashU, and they wrote these criteria for about 12 disorders. They published them, and they showed they're very reliable. The APA took those criteria, created a huge committee, nationwide committee, and developed DSM-3. DSM-3, with all its shortcomings, the Dr. Francis may discuss. I think he was going to be more keen on discussing the shortcomings of the 5, but the 3, with all our shortcomings, it's very reliable. It's very reliable. If you use the DSM-3 criteria to diagnose somebody with depression, I know what you mean. You mean 5 of 9 criteria. If you diagnose schizophrenia, it's 3 out of 5. It's usually the majority of the criteria. So you have now a system that can diagnose mental illness in a much more reliable way. The DSM, that process created what's called the Diagnostic Interview Schedule. The DIS is a set of questions that go over every single criteria, basically. And it has themes, right? If this is yes, ask those. If this is yes, ask those. Because, for example, in depression, you have 2 symptoms that have to be present, right? Anhedonia, lack of interest, and lack of pleasure, right? And depressed mood. One of the 2 has to be present. So if one of the 2 is present, you ask the other questions. So there is a system of questions, and it's a hierarchical system of questions. So those questions were used in the ECA and the NCS. Those big surveys would not happen without DSM-3, without a diagnostic system that is reliable, right? So the numbers we have are somewhat new because they depend on a development that happened in the late 1970s, which is, about 40 to 50 years ago. So the best numbers we have today are based on these big community surveys that use reliable instruments that we can now say that I can reproduce, right? That's the only way it can happen. It doesn't mean that it's perfect. It doesn't mean that is reality, but it means that I know what you did and I can do it. I can ask the same questions. And depending on the answers, I'll get the same results. So
it's funny, actually, probably my first foray into psychiatry was in about 2015. I was at WashU, and my job as a research assistant was just to kind of go through this very algorithmic, ask these questions basically using a computer program.
yes.
And I didn't have the context to understand what I was doing, but
Right.
that is exactly what I was doing, was just sort of following this algorithm. And it was, to be honest, it was a really amazing way to get to know people in this intimate way. And it's what really made me say, like, oh yeah, if I do this every day for the rest of my life, I won't really be working.
Yes, and it is very helpful, and I said very reliable. And I have to say that DSM-4 was an improvement because it added a number of things and it combined some criticism to DSM-3. And DSM-5 is another conversation that Dr. Francis can develop better than I can. So
sure. Psychiatry Boot Camp is brought to you by Beat the Boards. I am so excited to have Beat the Boards as a partner, because this is the question bank that I used to study for my own psychiatry board exam, and it made the exam a breeze. The Beat the Boards question style was so close to the style of questions on the real exam that I felt over-prepared during the test. Beat the Boards has courses in psychiatry and virtually every other area of medicine. Visit beattheboards.com to view the entire catalog and take advantage of Psychiatry Boot Camp's exclusive additional 10% savings by entering the word boot camp in the referral line in the shopping cart. Again, unlock these additional savings with referral code BOOTCAMP. That's one word, no spaces, BOOTCAMP. Psychiatry Boot Camp is brought to you by Simple Practice. Are you thinking about starting your own practice, but you're too daunted by the business and logistics? Or maybe you have a practice, but you're spending so much time on scheduling, record keeping, and billing that it's burning you out and slowing you down? Simple Practice is the solution for you. Simple Practice is an all-in-one EHR designed to help practitioners thrive. From admin work to clinical care, Simple Practice has a suite of tools that work together to simplify practice management. This includes e-prescribing and PDMP checks integrated within the app, and a lab slip template that can be easily sent to patients within the portal. With Simple Practice, you can spend your time on what matters most. For an exclusive 7-day free trial and 70% off 4 months, visit simplepractice.com/bootcamp. That's simplepractice.com/bootcamp. Okay, so how does understanding psychiatric epidemiology help us to understand the natural history, the natural course of psychiatric disorders?
Right. So actually a difficult concept in psychiatry is the fact that our conditions, they are chronic but episodic, which is kind of a contradiction, right? But if you have depression, suppose you have depression, it doesn't mean that you're depressed all the time. If you have depression, it means that you have recurrent episodes that happen over time, right? So the only way that I can understand the natural history of depression is if I follow a patient over time through those episodes and when they are not and when they do not meet criteria for those episodes. The only way I can do that is through long follow-up studies that we in psychiatry call cohort studies, that I can follow people through their lifetime. And what do we learn when we do that? We actually learn that we have a clinician bias, right? As a clinician, we see people at their worst. We see people when they're not doing well. And the truth is, on the long term, people do actually better than we think because of our own biases, right? And the only way for us to learn that is if we can have studies that follow people beyond when they need clinical care. So psychiatric epidemiology can develop that. The other reason that epidemiology can contribute is specific studies that look at specific age groups, right? For example, we didn't know the impact and the importance of mental disorders in children until we actually studied that population. Same goes for older folks. There are specific populations that have specific problems. The other main finding on long-term follow-up, I guess one of the things we may discuss is kind of the big findings in psychiatric epidemiology. One of them, of course, is the impact of what we call today adverse childhood events, right? We know that today because we had studied through their lifetime, and we can see, I mean, one of the data sets that I looked at in the past looked at the impact of adverse childhood events in the probability of being depressed after the age of 60. So there is a link that you can do if you have long-term follow-up of people that we cannot have in clinic, right? That we may not have in clinic.
Right. They're picking up things that when you are just a clinician dealing with people who are coming to you for healing, or when you're studying treatments, for example, you wouldn't be able to see these sort of signals to really understand what might happen if I'm not here. How is this person when they're not requiring care, et cetera?
Right.
Okay.
Yeah, right.
So how does psychiatric epidemiology help us understand what treatment actually does?
Epidemiology is actually a very simple science. It has very complicated modeling and mathematical modeling, but the very basic premise is actually fairly simple. Epidemiology starts when we want to understand why some people get sick and why other people didn't, right? So the classic example is people go to a picnic and eat some food and they have some GI upset after that. And then if you look at who ate what and how much, you can look at, you can attribute that this food was the source of this outbreak, mini outbreak. So epidemiology is basically the 2x2 table. And if you work with me long enough, you're going to probably get that I think about the world as a 2x2 table. I think it's the most helpful logical instrument we have. What does that mean? What it means is a 2x2 table is a combination of two yes/no propositions, right? So on one side, I have exposure. I have people that are exposed to X and people that are not exposed to X, right? X, exposure to X, yes, no. Outcome. The outcome is also dichotomous. If I want to make it very simple, the outcome is yes, no, right? Have depression or no have depression. Exposed to adverse childhood events and not exposed to adverse events in childhood. So, and here when things get interesting, right? A 2x2 table is structured as a yes, no, yes exposure, no exposure, yes outcome, no outcome. Allows me to calculate a very simple measure of association. That's called the odds ratio, the ratio of the odds, the ratio of odds of disease given exposure or non-exposure. So the odd tells me how closely related these two exposures, these two events are. Because I know that there are people that have adverse childhood events that do not have depression in the future, right? That the world is not perfect. The 2x2 table is never all in yes, yes, all in no, no. There's always people in the tables, in the cells that, according to theory, should be empty, right? But what I'm looking at is the unbalance of this distribution. I'm sorry if I'm getting to a little bit of the epidemiologic jargon, but that's what a 2x2 table gives us, a very simple way to look at probabilities, basically. And I'm looking at how unbalanced this 2x2 distribution is. I can use that for anything. Right? I can use that to look at people that are exposed to certain viruses, certain condition, people that are exposed to a certain drug and they have a specific condition. Well, you asked me about how can epidemiology help us understand about treatment. Well, you flip that. And instead of looking at exposure to a certain pathogen or to a certain adverse event, I look at exposure to a medication. So when I look at treatment studies, a clinical trial, to me as an epidemiologist, that's a mini epidemiologic study. The basic difference meaning that instead of the subject or history or life controlling the exposure is actually controlled by randomness, right? Because a randomized control study, actually, the clinician is not determining who gets the treatment, who doesn't get it. It's a randomized allocation of treatment. So it's funny, but people don't realize that we're kind of trying to mimic nature,
right,
by creating randomness.
That's
right?
the point.
Right. So we expose some populations to this medication, and then I have a group that are not exposed, and I follow their outcome on the other side, and I can see that this treatment, this exposure had impact on the probability of this outcome. So epidemiology is a very powerful tool if you can see it, and if you start looking at it that way, the whole world is an epidemiologic lab, basically.
And then we can make decisions based on actual hard, cold data.
Yes, and then you can make decisions in saying that. So, because what we do, and this is something that's complicated, but what we do in medicine is that we change in probabilities of specific outcomes. That's what we're doing, right? I don't speak like this when I'm talking to patients. I talk to patients, I say, look, this medication is not going to cure you, but it's going to, what I say, suppose it's depression. What this medication is going to do is going to make your depressive episodes shorter and less frequent. That's what it does. So instead of you suffering for 6 to 9 months, which is we know from some epidemiologic studies, that's the natural duration of a depressive episode, you're going to be better in 2 months. So that's what it does.
And then you can pull out your 2x2 table and sort of show them.
It's all a 2x2 table. Yes. I always have one in your pocket.
That's right. So would you be so kind as to share with us, you mentioned the adverse childhood experiences study, that being one major finding from psychiatric epidemiology. Any others that you think, this is a finding from my field that really new psychiatry residents should be aware of?
Yes, there are several. So let me start with something that I think added confusion to the field, not clarity. There are two sets of findings in psychoepidemiology that I think over time generated more confusion than clarity. The first one is a big finding. It's actually old now, from the International Schizophrenia Study. The International Schizophrenia Study looked at the outcome of people with schizophrenia across different countries. And one of their main findings was the Nigerian sample did much better than the US sample over time. And that study, that finding, to this day is used by anti-psychiatry movements to say that our medications are harming patients. So It go against most recent data, actually. We know that antipsychotic on the long term make people live longer, make people have less hospitalizations, less drug use. So we know that antipsychotics actually help people. So it was a confusing finding from the 1970s that to this day is still used to say, you see, these medications hurt people. That is a misunderstanding of the finding, is discounting the fact that the populations in Nigeria had much more community support, family support, less expectations, less dependency on, jobs that required skills. So it was completely misguided to compare those populations at one point. The second has to do with the black box warning that ended up in antidepressants for kids. And that comes from an epidemiologic study that showed that kids on antidepressant have a higher risk of suicide. Well, you can imagine how hard it is to study that, right? The risk of suicide in a population of depression that you cannot withhold treatment, right? You have to treat. So then who are you going to compare with? Because that's the key with epidemiologic risk, is your risk is higher. Well, it's higher compared to which group? Right? So what happened? What happened was there was a study, there was several, again, more than a couple of studies that showed that kids on antidepressant tend to have higher suicide attempts, more likely to have suicide attempts. And people say, okay, that's not the antidepressants doing that. The antidepressants is making them more suicidal. And that created a black box warning. And so we stopped treating kids with antidepressants for a while. That led to an increase in suicide attempts in kids because we were not treating them with antidepressants. So then they said, okay, take it back. The warning is still there. It's very interesting, actually. The effect of antidepressants, in particular SSRIs, on suicide risk is age dependent. There is a small increase in risk in populations under 25. There is no effect in populations between 25 and 35. And then it decreases the risk of suicide in older populations, because it all depends on the base population risk factor. It all depends on follow-up. It all depends on a number of factors. But that finding was very confusing. It's somewhat clear today that antidepressants help kids, should be prescribed. They should be monitored for suicidal behavior like any depressed patient. But it led to a lot of back and forth over time that was very confusing.
So you feel like that's mostly settled out now, where in an age-dependent way, people less than 25 may have a slightly increased risk of suicidal behavior briefly, but in the long term, treating the underlying depression with antidepressants overall reduce the risk. Is that right?
Yes. And it's still justified to use antidepressant in kids because although it may increase the risk of suicide behavior, the increase of suicide deaths was not significant. So it's different, right? One may have to do with disinhibition and a number of other factors. So that's where we are today. But that's generated a lot of back and forth over time. So those are some of the confusing studies that I think the epidemiology can create. In terms of what epidemiology has taught us, I think a number of things. First is that mental illness is more common than we thought. So if you look at the data from the NCS right now, if you include substance use, including substance use, about 60% of the population in their lifetime will have a mental disorder, right? So we're more likely than not to have a mental disorder in your lifetime. It's about 60%. That's one of the first findings, much more common than we thought. Second, gender has a very significant effect on how mental illness presents, right? Women, much more mood and anxiety problems. Men, much more externalizing substance use disorders. So we learned that over time. We know that based on these big studies. The third is that mental illness don't come alone. The level of comorbidity in mental disorders is extremely high. So our objects are not pure categories. That is like depression, alcohol use, anxiety, right? They seem to combine. So I think that we learned that from studies, from these big epidemiologic studies, that comorbidity is a big factor. We already spoke about the adverse events. I think adverse events in early life have a long-lasting impact on mental illness. We learned that from these big studies. And I will go ahead and talk about one finding that I find fascinating, and I find that people have a hard time discussing it, and that is suicide risk by race. So we all know about the issue of health inequalities in the US. It's very clear that African Americans, Spanish and Hispanic, and other minorities have worse outcomes in many conditions than the non-Hispanic population. Well, suicide is one of those that's the opposite. So suicide is much more prevalent in white non-Hispanic Americans than in African Americans, Hispanics, or Asians. Significantly higher. The only minority that suicide is as high as the white non-Hispanics is in the Native American population. But all the minorities, they have about half of the suicide risk compared to the white population. So I think some people are reluctant to talk about this because, there is this perspective of the minorities have to have worse health outcomes, so they find ways to counter this finding. But no matter how you look at it, half the risk is a significant change. So the suicide risk for minorities is about half, and it's interesting because it men and women. So it's for men and women. Men have 4 times more likely the suicide risk than women in general. And then when you look at minorities, the suicide rate among women is half of the white non-Hispanic population. White, so the women, all the women. So what I mean is the parallel changes. So the risk changes together. People have a hard time understanding this, again, because of this idea that they have to have worse outcomes. They don't. I think to me that speaks to the resilience of minority populations and communities. It speaks to the role of family. It speaks to the role of religion. It speaks to the role of community support and roles in life that I think minorities may have better developed and better structure than the white non-Hispanic population has. And I think the white non-Hispanic should learn from that, not say it's an artifact or it's whatever it is. So to me, that's a finding that we should discuss more openly and learn from it.
I love that. So you're saying this is settled now. This is no longer up for debate. There's been many, many studies on this. We have reliable numbers on these suicide rates. And you're kind of inviting us to ask the deeper question as to, okay, let's think more broadly about why this is and not try to wedge this into a simplistic narrative that may be propagated.
Yeah.
So those are some sort of snapshots that you've shown us, some major findings in the field, thinking more longitudinally about kind of what's going on now, where we're moving in the future. Are there any meaningful trends in epidemiology which you think our learners should be aware of?
Yes. So first is epidemiology serves as a way to improve our diagnostic criteria, right? One of the things we see in epidemiologic studies is that our criteria can be improved. They still can be improved. So I think improving diagnostic criteria should be something on the radar of every trainee today. I don't think we're going to be using these categories we have today in 20 years, right? I mean, you probably have had this conversation before with other folks, but there's a transdiagnostic model. There is the dimensional categorical model. So there are specific things that we may be using in 20 years that we don't use today. So diagnostic criteria, it's still in development. And epidemiology plays a role in that. The second is the role of genetics. Genetics is a field that is full of promise, and in part because our categories are not perfect. We tend to lag behind some of the epidemiologic findings, of genetic findings that other specialties are having, right? So like specific genetic mechanisms of disease, we don't have. The third is the full integration of neuroscience and psychiatry. This is something we have been talking for about 150 years of psychiatry as a brain disorder. And I think we are going to see that comes to fruition in a way maybe that we don't even understand what it is. Maybe there's AI engines will be able to see things in a way that we don't see. We haven't been able to break the code. But the human brain and neuroscience, I think, still have a lot to contribute to our understanding of human behavior. And I think when we do all that, we will still have something that is not explained. And that is, you may call it mind or soul, or whatever it is, different or more complex or complicated. There is something above the neuroscience, above a parallel, I don't know, that has eluded us because it has to elude us. Because if you're looking at neuroscience alone and biology alone, you never are going to explain everything. Maybe you will, maybe I'll be wrong, but we haven't been able to cross that in, I guess, 3,000 years. So we'll see.
Wow. So, this is a question that, of course, dates back before human history. And it reminds me of the Les Mis quote, to love another person is to see the face of God. And humans have been trying to describe sort of God for a very, very long time. And psychiatry is in the business of trying to describe humans. So, yeah, I think we're trying to look at something that is infinitely complex. And it sounds like you think maybe even impossibly complex, and use our limited resources to describe the complexity of this being. And what you're telling us is that trends in psychiatric epidemiology are showing us that indeed psychiatry is a bit different. The questions that we are trying to answer are more complex, transdiagnostic, multidimensional, etc.
Yes. And I guess so there is this old paradox that says that if the human brain was simple enough that we could understand it, it could not understand it. Right? So it's circular. But
yes, that would make my head explode. I think that makes perfect sense to me.
It's a little bit circular. But psychoepidemiology is a tool that can for us to understand behavior by looking at the distribution of disease in populations. What makes this population different than that population? It is, there are a series of factors, and that is how epidemiologists can help us move forward. Is because I'm not looking at just one individual behavior. I'm looking at groups of people that I put together, and that allows me to, in a way, as I said, look at the world as a big lab, right? Because people are putting themselves in these categories all the time, right? Okay, I'll give you another paradox for you to think about, because we know that smoking causes cancer, right? Actually, I should have listed that as one of the key findings in psychiatric epidemiology, was the finding that cigarette smoking causes lung cancer, right? So that's basically a fact. The paradox is, and this is something that we discuss in epidemiology courses, the paradox is, if everybody smoked the same amount, lung cancer will be caused by genetics only, because everybody had the same exposure. And only those that have the specific genetic traits would develop the outcome. So the development of the outcome depends on exposure, right? And depends on difference of exposure across groups. If everybody had the same exposure, there's nothing for me to do. So we all expose ourselves to different things. Life exposes ourselves to different things. And those things, it makes us who we are and makes us our life and create our narrative. So we are the product of these different exposures. And looking at the product, I can understand how much the exposure played a role on this.
And it's only by comparing groups systematically that we can have a better understanding of that.
Right. Because one life is not enough, right? I mean, if I look at just one individual, I just have one life, one set of exposures, and one set of outcomes. I have to have different individuals with different exposures and different outcomes and try to put them together. That's kind of what this is. It's a tool to understand people because we all have this one life. So by now I can compare multiple lives, thousands of lives.
I think that's one of the reasons that a lot of people go into this field, actually, is that, we are very limited in the people that we interact with in our own lives. And so by doing a job like this, where you get to know people so intimately, so many different people, so many people that you would not otherwise interface with, you're expanding your body of evidence. And in just strictly speaking, selfishly, it's allowing me to discover more and understand more about what it means to be a human.
Yes.
Okay, so this is sort of a very fundamental question that you had mentioned as we were setting up this episode. I'm very interested in your thoughts on it. I think this is sort of like the question, and I don't just mean that for psychiatrists. This question goes back and back, cuts across disciplines. I think a lot of ink has been spilled about it for centuries, and it's this sort of nature versus nurture question. Do you think that psychiatric epidemiology can lead us to a better understanding of this fundamental nature versus nurture question?
Yes, and it's probably one of the key tools for that. Why? Because the question of what is innate and what's environment is the crux of this question, right? Is what is the individual? In a way, is genetics. Let's say genetics, right? Genetics is, in a way, can play the role of nature. In the environment, is nurture, right? Is the notion that environmental factors play a role over this specific individual and will create the outcome. This question I think, can only be studied by looking at groups of people if you can do the right grouping of peoples. Because again, one life, we all have just, this one line. I need to have more lines to have a clear understanding of that. Genetic epidemiology is doing exactly that. It's trying to answer that very question. And some of the key studies on this have been done actually first at WashU, which was looking at sets of twins, right, that are reared apart and the outcome of them over time. What happens to them? How much of that? And I'll tell you, there is a key finding, and it is an important finding, and maybe has been questioned, but it's in one of the original psych epidemiology textbooks from WashU. One of the studies looked at identical twins that are children of alcoholics, and they are reared apart. They have been adopted in different families, and they looked at kids that are not children of alcoholics, but they are raised by alcoholic fathers, right? So you have the genetic kid that had a father they have the genes for an alcoholic father being raised by a non-alcoholic, and you have kids that don't have that genetic background but are raised by an alcoholic father. Which one of the two has a higher risk of being an alcoholic? The answer was the kid of the genetic alcoholic. And alcoholism is a very complex behavior. It's a very complex behavior. And we, even with not having the father as a role model, right? He was being raised by a non-alcoholic father. Those genes determine the risk of alcoholism being higher on that kid than on the kid that had a father that was drinking and being kind of a role model. So in a way, that in that particular example, nurture loses, right, to nature.
That's about as cut and dry as it gets.
This is clear, and the same question has been asked with criminal behavior as well, and nature wins too.
Huh.
The genetic stuff, the genetic epidemiology stuff. Every time I read it, I'm impressed by how powerful nature is on that nature versus nurture conversation.
Final question for you, and this actually is a little bit off topic, but I saw that you did do a TED Talk on this. Mm-hmm. For our young trainees, do you have any tips, pearls for them about how to make our work more meaningful?
So there is I guess a tip that you may want to use in life in general, and that is the tip of habituation. Habituation is very, very powerful, but you pay a price for it. The price of transforming something into a habit, which I'm going to have you do as my resident, right? I'm going to have to create a habit that you ask about suicidal questions. I'm going to have to get into the habit of asking about substance use. I'm going to have to get into the habit of, having good bedside manners. So there's a lot of habituation in life. You have to develop habits. So I'm taking you back all the way to Aristotle and the power of habit is something that Aristotle talked about 300 years before Christ. So habituation is very important in this part of life. We train, we create habits, and they are super helpful. They are, I think, a shortcut for a lot of things, and they're wonderful. I'm a very big fan of habits. What's the price you pay for a habit? The price you pay for a habit is the loss of the fascination with the new thing, right? It's the loss of the awe, right? It's the loss, oh my God, I am a doctor. Oh my God. So the example I give is, remember the first time you flew, that you went on a plane. Remember the first time you went on a big jet plane and everything was magical, right? The seats and the smell and even the food and looking at the wings. And now I'm looking at the clouds and I am, I'm flying. That's just so amazing. And then fly becomes a habit and it's boring and it's terrible and you hate it and you wish you can, you wish you get it to your destination as soon as possible. Reserve a little bit of that awe for your everyday. No matter how many habits you develop, that you're going to have to develop, and that will help you in life. Reserve a little bit of that awe, saying, I dreamed of this for years, right? I'm now a medical student. I'm now a resident. Oh my God, I'm now an attending. I'm that big shot attending that that I was looking up to when I was a student. And then you become, an associate professor, and I become a program director. And I'm a chair. And I've been a chair now for 2 years, and I'm creating chair habits. And but I have to remind myself of the privilege that I have to be in this position, and the responsibility and the awe of being in these positions. So if all of us could reserve a little bit of awe, a little bit of, this is the first time I'm doing this. Every time I'm doing something that I've been doing for 100, 1,000 times, keep the habits, they'll help you. Keep the habits, but don't pay the full price. Don't pay the full price. Keep a little bit of awe every day. And that will, I think, bring meaning to make things meaningful, and instead of just meaningless jobs and tasks or electronic medical record checkboxes. So
drop the mic. We're going to end the episode there. We'll give our listeners a chance to meditate on that. Those are wonderful, wise words. Enough said. Let's just go ahead and outro and let everybody sit with that and where they can find awe in their lives. Thanks for coming on the podcast, Dr. Messias.
Thank you for the opportunity to have this conversation.
Thanks for listening to this episode of Psychiatry Boot Camp. Please leave a rating and review. If you have questions or feedback for me, you can email me at psychiatrybootcamppodcast@gmail.com. The opinions shared in this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete, accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice.